Hi everyone, this is Professor Widener. Today we're going to go over Chapter 9, Gastrointestinal Function. The GI system is responsible for the consumption, digestion, and elimination of food. It provides the body the nutrients, water, and electrolytes needed to maintain bodily physiological activities. There are two parts. We have the alimentary canal, which include the structures through which the food is passed, which includes the oral cavity, the pharynx, the esophagus, stomach, small intestine, large intestine, and anus. Then we have the accessory organs that aid in digestion, and those include the salivary glands, the liver, the gallbladder, the bile ducts, and the pancreas. Disorders in these systems result in nutritional deficits and metabolic imbalances. They can be mild to severe in nature and often originally present as vague, nonspecific complaints. As we have with the other chapters, we're going to go over the pathophysiology first, and then we'll go through some of the disorders. There are 4 layers to the GI tract. The innermost layer is called the mucosa. Its job is to produce mucus and facilitate movement of the GI contents and protects from erosion of the stomach from the extreme pH conditions that are needed for digestion. Next is the epithelial mucosa, which has high turnover rate because of the erosion associated with the passage of food in the highly acidic environment. Next is the submucosal layer, which is connective tissue that actually contracts and releases itself, which is responsible for peristalsis, which is the wave-like motion that food moves through the tract. And then the serosa is the outermost layer. The peritoneum is a large serosa membrane lining of the abdominal cavity. So that literally lines the whole entire abdominal cavity. So when you hear someone has peritoneal irritation, again, it doesn't really point us to one specific thing because the mucosa covers the entire abdominal cavity. We're going to talk about the upper GI tract first. When the food enters the mouth or the oral cavity, chemical and mechanical digestion begins. Chewing breaks the food down into small pieces, and saliva breaks it down to start carbohydrate digestion. And there are antibodies that kill bacteria and neutralize them. Smell, taste, feeling, and the thought of food triggers the olfactory nerve, which is cranial nerve 2, to start saliva and gastric production. And if you look at figures 9.1, this gives you the function and the of all the different gastric juices that are within the GI system, and it's really important to have a good handle on what the different types of hormones do. I'm not going to read that over to you, but just I'll talk about them as we go through the chapter. The tongue is responsible for moving the food bolus to the back of the mouth to be swallowed. This is all voluntary actions at this point. Then when you're ready to actually swallow, that reflex is triggered by the trigeminal cranial nerve, the glossopharyngeal nerve, which is number 9, and the vagus nerve, which is X. This is an involuntary movement. The nerves relay information to the swallowing center in the medulla pons that triggers the food to move from the mouth across the pharynx into the esophagus, preventing aspiration. So just as like a food for thought to think about when you see a patient who's had a stroke in the medulla or the pons, that interferes with their swallowing center. So that's one of the reasons that they have dysphagia. If you look at page 396, they have really good diagrams of all this there that can kind of help explain it. Once the food is in the esophagus, it has muscular rings that move food down the esophagus. When the food gets near the stomach, the esophageal sphincter relaxes. With the relaxation occurs as a result of the vagal impulses in the hormone progesterone, secretin, and glucagon. Again, remember, we're hearing about the vagus nerve. So when that vagus nerve gets overstimulated, like when you're vomiting, that's why people might pass out when they get nauseated, because again, you're stimulating that vagus nerve. Now we've got the food into the stomach, and the stomach is an expandable reservoir basically for food and liquid. Prior to the food's arrival, the gastric acid secretions begins to prepare for the food arrival. As the stomach fills, the rugae, which are the little grooves in the stomach, expand. The stomach is actually able to hold up to 4 liters, which I read that and I thought, man, that's really a lot of liquid. The rugae have gastric glands that secrete various substances. And again, we're back to that table on page 394 that shows us all the gastric juices that are there. Nutrients are not absorbed in the stomach, but alcohol, NSAIDs, and aspirin are. So think about when you've been out and you've had a few drinks and you feel like those few drinks make you feel a little buzz faster than if you had a full stomach. Well, this is why, because the alcohol gets absorbed faster in the stomach if there's no food in it. Alcohol absorption is not as fast if you have food in your stomach. So good to understand. This is also why we tell you not to take NSAIDs and aspirin on an empty stomach. So again, they don't get absorbed as fast and break down the lining of the stomach. Once the digestion is complete there, the food is now turned into something called chyme. Chyme leaves the stomach in small amounts through the pyloric sphincter into the duodenum, where the liver and pancreatic secretions are added to it to aid in digestion. Now that we've got the food moving through, we're going to talk about the lower GI tract. The small intestine, or the includes the duodenum, the jejunum, and the ileum, and the large intestine includes the cecum, the colon, and the rectum, and it also the anus is part of the lower GI tract. Interestingly, we always knew the bowels are long. The small intestine is about 20 feet long. It allows for adequate absorption of the nutritional components. It allows for digestion of the food, and carbon dioxide neutralizes, sodium bicarbonate neutralizes the pH and secretes enzymes that facilitate digestion. Immune cells neutralize any remaining bacteria, carbohydrates, proteins, bile, fats, and vitamins are all digested here. Intestinal motility is controlled by the vagus nerve, enteric nervous system, which the enteric nervous system is the nervous system that controls the GI tract, and that's part of the autonomic nervous system specific to the GI system, and various hormones. The small intestine ends at the cecum, which is also where the appendix is attached. It takes a few hours for the food to actually move to the large intestine. That is about 5 feet long, and it is 2 times the diameter of the small intestine. Here is where the water, unabsorbed food molecules, undigestible food, and electrolytes come. The colon is responsible for absorption of 90% of the water and the electrolytes. There is E. coli in the colon that feed off of the undigested food. There's a large population of bacteria in the colon, and their job is to synthesize vitamins, key vitamins, such as all the B's and vitamin K that are later absorbed by the large intestine. So again, think about just how frequent we see E. coli infections, and we think, oh, where did they come from? And remember, the way the anatomy is that, as particularly with women, their anus is close to their urethra. So this is where a lot of E. coli infections come from. Again, the chyme moves through the colon and changes into a fecal mass. The muscle movements move stool from the sigmoid colon into the rectum via the rectosigmoid sphincter. The rectum can hold the stool typically between 16 to 18 hours. And then the enteric nervous system and the spinal cord send a message to elicit the defecation reflex. So again, think about there, when you have people who have spinal cord injuries, that depending on the level of their injury, they may lose that defecation reflex. Defecation requires both a muscle tone and a nerve intervention. Next, we're going to talk about the liver. And if you go to page 399, there is a chart there right under liver. The liver is a very small part of the body, but it requires 25% of the cardiac output to function properly. The hepatic artery carries blood from the general circulation to the liver, and then the portal vein carries partially deoxygenated blood from the stomach, pancreas, spleen, gallbladder, small and large intestines. The liver can process nutrients and digest them. The interesting thing about the liver is the amount of cardiac output that it requires. That's because it has over 500 different functions. And when you think about the liver, I want you to think of it as like it's like a filter. So if you look there at that list, I mean, there's many things that it does, but it metabolizes carbohydrates, proteins, and fats. It stores glucose. It detoxifies blood of potentially harmful chemicals like alcohol and nicotine and medicines. It maintains intravascular fluid volume. It metabolizes medications to prepare them for excretion. It removes damaged and old erythrocytes from the blood to recycle iron and protein. It serves as a blood reservoir, as it has approximately 450 mLs of blood that can be used when needed, and it converts fatty acids to ketones. The job of the liver is just enormous, but those are a few of the highlights. The other interesting thing about the liver is that it can regenerate with only 25% of it remaining. It can regenerate as the hepatocytes act as stem cells. While this is happening, you want to take extra good care of the liver by avoiding hepatotoxic materials or medications. Hepatocytes produce bile salts necessary for the emulsification of fats and fat-soluble vitamins so they can be absorbed in the small intestine. These vitamins include A, D, E, and K. Bile enters from the liver through a duct system to either to the gallbladder for storage So the bile leaves the liver through the duct system and enters the gallbladder for storage, and then the rest moves on to the duodenum. The other associated organ here is the pancreas. The pancreas has endocrine and exocrine functions. The pancreas is located under the stomach and liver. Its exocrine functions include producing enzymes, electrolytes, water to aid in digestion. And again, look at table 9-1. Its endocrine functions are to produce insulin, glycogen, and other pancreatic enzymes to regulate glucose control. I want to go back a minute too and talk about the gallbladder. The gallbladder acts as a storage unit for the bile. It is about the size of a golf ball, and it's under the surface of the liver. When the chyme is in the small intestine, it triggers the gallbladder to contract, releasing the bile into another duct system where it travels to the small intestine. If for some reason the gallbladder has to be removed, bile is constantly flowing through the small intestine, which is why people may have diarrhea or digestion problems after having their gallbladder removed. Some of the changes that happen with aging related to the GI system includes reduction in stomach acids, decreased blood flow to the associated organs, which delays clearance of medications. The small intestine decreases absorption of calcium, which is one of the reasons why we have to supplement calcium as we get older. And with decreased peristalsis, there's an increased risk of constipation in the older folks. And now you understand why. You know how older folks are always focused on their bowels. Well, that's because they have decreased peristalsis, which puts them at higher risk for constipation. So that was a mouthful, but I hope all that makes sense. Make sure you look at the diagrams in your chart. We're going to start going through some of the associated disorders now, starting with the upper GI system. The first one we're going to talk about is cleft lip and palate. It is the most common craniofacial malformation at birth. It develops in utero between week 4 to 9 gestation. Again, one of those things that develops most of the time before women even know that they're pregnant. The causes are multifactorial. We don't know specifically which one, but we do know that it could be related to genetic mutations, maternal diabetes, drugs, specifically anticonvulsants, toxins, viruses, vitamin deficiencies, alcohol consumption, and cigarette smoking. This happens when there's failure of the cleft palate to fuse in development, creating an opening between the oral and nasal cavities. A lot of times, our ultrasound technology has gotten so good now that they actually can typically diagnose this in utero. And typically, when these babies are born, they may need special nipples to help them eat. They may need supplemental feeding tubes, specific dental appliances. It is necessary to have a surgical procedure. The first procedure is usually done within 3 months. If they have a cleft lip and if there's a cleft palate, the first surgery is usually done within 18 months. They're actually testing in utero surgery so that there are no scars on the baby's faces. But again, the treatment is surgical and then temporizing measures to keep the baby hydrated and nutritionally sound until they decide what the best course of action is. Esophageal atresia is when there's a congenital malformation of the esophagus. It's in two separate sections. There is a upper section and a lower section, and these sections are not connected. Typically, the lower half of the esophagus is connected to the trachea. It's a form of a fistula. You do not need to know the different types. And I just said it's associated with the fistula. Prenatally, it can be diagnosed and suspected if there's excess amniotic fluid, but typically they won't find this until the baby's born and they have immediate complications after birth that include drooling, choking, difficulty breathing, inability to swallow. They can evaluate this with a catheter. They also check for other conditions via EKG, renal sonogram, and an X-ray. The initial treatment is to continuously suction the esophagus, and the ultimate treatment is surgical repair. Pyloric stenosis is narrowing or obstruction of the pyloric sphincter. This manifests itself a few weeks after birth. You may note that there is a hard olive-shaped mass in the abdomen. The baby has persistent vomiting, hunger, regurgitation and belting, failure to gain weight, dehydration, and pH imbalances. Again, the specific causes are unknown, but they're thought to be multifactorial in nature. The diagnosis is made by a history and physical, an abdominal ultrasound, and blood chemistries and CBC. The treatment is giving the baby biliary and liver enzymes for jaundice. Ultimately, the first thing that they want to do is support the child through correction of the fluid and electrolyte imbalances and pH imbalances. A balloon dilatation may help, but ultimately they usually need surgery to open up the pyloric sphincter. Dysphagia is basically difficulty swallowing, and there are a number of ways that this can develop. It's usually a secondary condition, something else. Mechanical causes include congenital atresia, as we just talked about, esophageal stenosis, esophageal diverticulum, esophagitis, or a tumor. Neurological manifestations include a stroke, traumatic brain injury, Parkinson's, Alzheimer's disease, Huntington disease, cerebral palsy, multiple sclerosis, ALS, and Guillain-Barré. Neuromuscular disorders include muscular dystrophy. Psychiatric conditions for dysphagia include severe depression or anxiety, somatic form disorders, conversion disorders, and eating disorders. People can also have what's called a functional dysphagia, where there is a sense that the food or liquid of the food is lodging or sticking in the back of the esophagus. There are also what we call iterogenic causes, and examples of those would be if someone had a laryngectomy, a tracheostomy, they're intubated on the ventilator, radiation side effects, or medication side effects. Clinical manifestations include the sensation of food being stuck in the throat, coughing, pocketing in the cheeks. This is one of those, if you've had a patient who's had a stroke, they typically will not recognize that they're having dysphagia. But again, with the nurses being at the bedside, if they come and tell you the person is having difficulty swallowing, you want to consult our friends in speech therapy to help assess for this. The diagnosis includes, again, a history and physical exam. And the way to diagnose this is you can do it through speech therapy, through x-rays, but a barium swallow where you can actually watch the food swallowing to see the cause is the core treatment. Treatment basically depends on the cause. And there you take interventions to preserve the nutritional status and prevent aspiration. Sometimes surgery can be necessary. They're also using Botox injections to help with this. But the most important thing is to help people maintain their nutrition and prevent aspiration. If they develop dysphagia after like a stroke and they're not able to eat, obviously that's when we need to have considerations of talking about end of life issues and the need for a possible PEG tube. Vomiting is a voluntary or involuntary forceful ejection of chyme. It results from a wide range of things, but it can be from a virus, a drug overdose, increased ICP, severe pain. Some people can get it from a car ride. There's lots of different things that can happen. If someone has recurrent vomiting, they're at risk for fluid and electrolyte imbalances. And because of the high pH, they're at risk for breakdown of the esophageal tissue. The significance of the vomitous characteristics is important. For instance, if it's yellow or green bile contents, that means it's coming from the small intestine. If someone vomits bright red blood, it's coming from the stomach. And if someone vomits coffee ground colored material, that's probably significant for an upper GI bleed as well. Diagnosis includes history and physical exam and blood chemistries. Depending on where you are, you may want to do some imaging. But the focus is really on cessation of the vomiting and correcting the electrolyte imbalances. The treatment is really, the bottom line is you have to find the cause and then treat the cause to prevent the dehydration and electrolyte imbalances. A hiatal hernia is when the stomach section protrudes through the diaphragmatic cavity. The sliding hernia is the most common, significant for about 95% of the cases. These influencing factors can include congenital malformation, iterogenic factors, which can include post-gastrectomy, lower esophageal surgeries, and trauma. They can also happen after traumatic injuries, and they also are more common in people with advanced age and smoking. Hiatal hernias can be exacerbated by increased thoracic pressure from coughing, vomiting, or strains, and intra-abdominal pressure caused by pregnancy or obesity. Clinical manifestations reflect inflammation in the esophagus and stomach. Some of these clinical manifestations include indigestion, heartburn, nausea, chest pain, and frequent belching. Frequently, it will also be worse when people are in the recumbent position when they are eating, bending over, or coughing. Again, this can be diagnosed by a barium swallow, upper GI x-rays, manometry, which we really don't use that much, and EGD. Treatment involves relieving the inflammation and healing the mucosa. So some of those treatment options include small frequent meals, avoiding of alcohol, sleep with the head of the bed up 6 inches, smoking cessation, losing weight, antacids, and H2 blockers. The other interesting thing about a hiatal hernia is if you have a person laying on the table and you have them sit up like to squeeze their abdomen, sometimes you can see the little piece of hiatal hernia there come up. Gastroesophageal reflux, this is when chyme backs up into the esophagus. There are different factors that influence that. Some of those things include medications, coffee, alcohol, obesity. The clinical manifestations include heartburn, regurgitation of food, nausea, reports of a sour taste in their stomach, a dry cough, laryngitis, pharyngitis, a lump in the throat, and chest pain. Chest pain for GERD and peptic ulcer disease can feel very much like a cardiovascular pain. So it's very important to be able to distinguish between the two. But again, if someone presents to your office with chest pain, through your HPI and asking questions, you're gonna figure out if you can decide whether it's GI pain or heart pain. But again, if you still don't have a clear picture, you want to basically triage to what is going to hurt the patient first. So they're not going to die from GERD right away or reflux. So again, get an EKG on that person. And if their EKG is normal, it gives you some more time to figure it out. But if their EKG is not normal and they're in your office, then you can get them to the hospital so they can get the treatment that they need for their heart disease. So again, we're not always going to know what the problem is, but we're going to know how to figure it out. So just keep that in the back of your head. Diagnosis is going to be made by history and physical exam and an EGD for diagnostic testing for concerning presentations. GERD is one of the most common reasons for chronic cough, along with asthma and postnasal drip. Persistent GERD puts you at risk for something called Barrett's esophagus. That is where the normal esophageal squamous epithelium becomes metaplastic columnar epithelium. So again, think of the changes in those patterns of the stomach lining. Those changes can lead to, again, if it's not controlled, they can lead to stomach cancer down the road. We do know once you have Barrett's esophagus, it can be controlled with acid reducers, antacid, and mucus blocking agents such as Carafate, and at times surgery is sometimes needed. Gastritis is an inflammation of the stomach's mucosal lining. Acute gastritis is usually caused by some kind of neutrophilic infection, either an autoimmune disease, a virus of some type. It can be from an external or internal irritant, severe stress, or H. pylori. Chronic gastritis is associated with the presence of lymphocytes, plasma cells, and macrophages that proceeds through the phases to gastric atrophy. As a word of caution here, there are two types. There is type A, which is generally has an autoimmune cause, and there's type B caused by H. pylori. When you're thinking about how to diagnose someone for H. pylori, please keep in mind that there are many different ways to test for H. pylori, through stool, through a biopsy. But please know that when you get a serum H. pylori, like a blood level, you cannot tell if that H. pylori is acute or chronic. So it really does little to help you solve the problem if there is an acute H. pylori infection. So please just remember that. I've seen in emergency rooms where providers will treat on an H. pylori serum level, and it's not necessarily indicative of an acute or chronic infection. It just tells you that it's present. It may have been there for a long time. Some of the clinical manifestations include nausea, heartburn, gastric pain, nausea, vomiting, anorexia, malaise, feeling full with a smaller meal intake. And the other thing with chronic gastritis, there are increased risk for peptic ulcers, gastric ulcers, anemia, and gastric hemorrhages. This can be diagnosed by doing an upper endoscopy, which is where the gastroenterologist will put the scope down their throat to see exactly what's going on. H. pylori testing, which again, the best ways to do that is through stool, a breath test, or a biopsy. People may also require a CBC and stool analysis, and the stool analysis is to check for different types of infections that could be present. Treatment options. Acute gastritis usually resolves on its own and its supportive symptoms if they come to you sick enough to actually be seen at the doctor's. Disease management for chronic gastritis includes the goal to basically limit the complications And you can do that by doing all the things that we've talked about: eating small, frequent meals, avoiding alcohol, smoking, losing weight, H2 blockers, and proton pump inhibitors. Peptic ulcer disease. These are different kinds of lesions that extend into the mucosa. The risk factors include NSAID use and H. pylori infections. Duodenal ulcers account for 80% of the peptic ulcers, and they are most common between 20 to 50-year-olds. This is where there's increased gastric excretion. These folks often present with epigastric pain, weight loss, and increased pain at nighttime. Gastric ulcers are common between people 50 to 70. They are not as frequent, but they can be more deadly. These are the people that are going to come in with severe pain and they're going to be vomiting blood. That is, you want to call your gastroenterology friends quickly, because that gastric ulcer needs to be cauterized. You again would treat this with common ways to decrease the acid in the stomach and the small healthy meals, similar to the things we've been recommending. There's also comes a stress ulcer, which develops because of some kind of major physiological stressor, which could include burn, sepsis, trauma, head injury, basically any kind of excessive trauma that is out of the norm. There's also then the Zollinger-Ellison syndrome. This is where excessive gastrin causes excessive gastric acids, and the people often present with some type of chronic diarrhea. Clinical manifestations, again, can include a GI hemorrhage, obstruction, perforation, bowel penetration, and peritonitis. Those are kind of the extreme ends of the peptic ulcer. Some people are just going to present with some nausea, some stomach aches, some more similar symptoms to our other GI problems we've been talking about. Diagnosis is done by EGD for confirmation. You may do a urea breath test, CBC, stool analysis, and H. pylori antibody levels. Treatment is similar to that of gastritis. Cholelithiasis is formation of the stones inside the gallbladder. Risk factors include advanced age, fair-skinned women, obesity, high-fat diets, rapid weight loss, pregnancy, or hormone replacements. There are 3 different types of gallstones that can form, and if you look on page 414, you will see table on 9.2 that there are the 3 types of stones are cholesterol, bilirubin, and mixed, with cholesterol being the same, the most common. When these gallstones are small, people are mostly asymptomatic. However, they may, up to the point of a gallbladder attack, experience some intermittent symptoms, which are called biliary colic. That is when the gallbladder is contracting to try and move the stone. People often have pain in the right upper quadrant, into the epigastric area, and around to the back. Complications of this can include acute cholecystitis, which is inflammation of the gallbladder from obstruction. The manifestations are similar, with the pain in the right upper quadrant, into the epigastric area, and around to the back. Acute cholangitis is when the gallstones have moved into the common bile duct, and they also have, on top of being a stone, they also have an infection. And these folks present with fever, jaundice, and abdominal pain, which is called the Charcot triad. To diagnose cholelithiasis, you may see an abdominal ultrasound. You may see a X-ray, but that's less common. You probably see a CT of the abdomen and pelvis. You may see an ERCP, which is where they actually typically is done in the OR by a gastroenterologist, where they do an endoscopy to see if they can actually remove the stone. An MRCP is an MRI that actually looks to see if there are any stones in there. And on serum lab tests, you may see increased liver enzymes, and is typically going to be your main sign. All these sudden, these people who have been normal are going to have, elevated liver enzymes, and they're going to have jaundice. Treatment options include pain management. Sorry for the interruption of my dog there. Pain treatment typically includes pain management, calculi removal, restoration of the bile flow, and prevention of reoccurrence. With that, we encourage a low-fat diet. Sometimes people need antibiotics, and sometimes people need bile salts to help dissolve the stones. I'm going to stop this lecture right here, and then we'll move on to disorders of the lower GI system.